it's time for me to introduce the first panel, which is Transforming Medi-Cal for Children, Future Visions and Innovations. Okay. Yeah.
Nancy, you go before Kim? Or Kim? Kim goes first. Okay. Good morning, everybody. As I was driving in this morning, I was, for those of you who don't know, I'm a recovering bureaucrat and a defunct therapist. And one of the things we often say in therapy is dialectics abound, meaning two things can be true at once. And I really heard in Wendy's comments this morning something I'm going to ask you to hold as we do this panel, which is we are in a moment of unprecedented villainy. Our federal government is vilifying compassion, and we are experiencing one of the most significant cuts to the America's safety net. It's real, it's happening. We're experiencing it right now. 40% of people with subsidized insurance on the exchange have already lost coverage, and we're going to hear a lot more about those challenges. We're also in a moment of unprecedented consensus that is a uniquely difficult time to be young in America. And I'm now working in a number of red states across the country, and I'm finding allies across the political spectrum. So as you listen to us today, we're going to break down both the challenges and the opportunities, because some of the things that we've been working on as a state are sweeping the nation, frankly, in terms of our reforms of our children's mental health system. So the opportunities are still there for us to do better, and we're going to talk about those today, but we're also going to dive right deep and hard into some of the challenges of H.R. 1 and more. So Kim, with that, do you want to take it over?
Slides. Is this here? All right, here we go. You're a little taller than me, I think, Alex. Thanks, it's great to be here. Thank you to Family Voices of California. My name's Kim Lewis, and I am the Policy Director for the National Health Law Program's California office, and also the Managing Director of the practice areas. It's great to be with you. I'm going to have slides that I guess means you're going to look that way or that way instead of at me if you want to see what I'm talking about. But I think, as Alex said, these are unprecedented times for us. I was marveling at the name of the panel because it was like innovation and opportunity. Like, all right, I hope that you don't stop listening to me, because that's also what we need to be thinking about and talking about. Which is that there are opportunities and hope, I think, abounding, even though we are in unprecedented times, and that the federal government and the current climate is very, very hard for families, is very, very hard for everyone, really, who depends on the safety net, particularly Medicaid. So, this is the work that we do. This is the fight that we are in every day, and we will not stop until we succeed. So I'm going to talk a little bit about H.R. 1, as some of you may have heard about it. It's the, some of us call it OBA, which is not a name, that you really want to think about, because it's, one big beautiful bill act. It's not the way we think about it, but it is the way that they named it, because they wanted you to think it was a really positive thing for beneficiaries of Medicaid, and that's not really how this bill is. So I'll call it H.R. 1, but it was signed into law by the President on July 4th, ironically, last year. And really, it's the biggest cut to Medicaid in the entire history of the program. It's $1 trillion of federal funding being lost by states collectively, and reduction in Medicaid eligibility, cuts to state funding in a variety of different other ways. And so I'm going to talk about a few of the items that were in that bill. Obviously, there's a lot more, and I'm not going to cover it all because of the time we have together, but just want you to kind of understand the context of this bill. All right, so on these slides, we're going to talk about the first kind of major part of this legislation, which is the new work requirements, or some people call it community engagement requirements. And that's essentially a new requirement that people who got on Medicaid as a result of the Affordable Care Act, what we call sometimes the expansion population or the MAGI, modified adjusted gross income population. These are adults, essentially 19 to 64, who got on Medicaid as a result of the Affordable Care Act, and now will have to, in 2027, meet the new work requirements criteria to stay on or to get on the program. You know, you can also engage in community, what's called community engagement, where you can do community service, or you can be part-time in an education program or in a work program. So it's not always just about being able to work, but the requirement is essentially an 80-hour a month of work requirement in order to stay on the program or to be in one of these other alternatives. The important thing I want to leave you with today is that there are exceptions, and there are many of them, and we're not going to talk about all of them, but I think you want to know that there are exceptions to this requirement, and particularly this is going to impact, you know, those obviously youth over 19, but also parents, caretakers who have youth that are not, you know, that don't automatically meet the criteria for an exception. So we want you to be paying attention, and I know Nancy's going to talk about some of the recommendations for you on this. So essentially, you know, I want you to look at the exceptions on the slide around who is going to be able to be exempt from this requirement. And that the first group is really parents, guardians, caretaker, relatives of those who are either disabled of any age or who are the parent, caretaker, or guardian of a child under age 14. So that's 0 to 13, essentially. Those folks who have that child at home or who are taking care of a dependent adult will be exempt from the requirements here. The other group that I think is really important that you may or may not be thinking about is foster youth of any age and former foster youth up to age 26. Those are youth who were in foster care and formally left the program at age 18, so they were in foster care on their 18th birthday, and now they're under age 26, so we call them former foster youth. So they're also exempt. And then there's another group that's what we call, and this is really kind of a very complex group, but it's called medically frail populations, and that is also persons who will have special medical needs, which is yet undefined. And so the thing about the medically frail group, although there's a number of the categories on the slide, is to understand that the federal government has yet to issue guidance on these requirements. Some of the guidance they've issued thus far has not been detailed, has not gotten into specifics around who has to do what is medically frail, what qualifies, what doesn't. So we're going to end up seeing some specific guidance from the federal government. It's due by June 1st of this year. It has not arrived. So when states are talking about rolling out these requirements and you meeting a medically frail exception, they're doing this based on what they know now, as opposed to what they will know more specifically when the federal government weighs in on this and specifically has a rule that says it has to be done this way or that way. So I really want to qualify that because that's really important that the state says, you know, this is what we're doing today. It doesn't mean it isn't subject to change. So that shouldn't confuse you, but it is confusing, I know. So being blind or disabled according to the Social Security Administration criteria, that's obviously an exception for medically frail. Having a substance use disorder is one of the criteria, which is pretty broad when you think about it, because what does it mean to have a substance use disorder? It could be really being in any services or anticipating being in services. Again, we don't know what's going to be required to verify this. It could be raising your hand, it could be self-attestation, but again, we don't have the specifics yet on what is going to be required to meet the criteria yet. Having a disabling, it says, mental health condition. We don't exactly know what disabling is, but we're hoping that states, again, broadly interpret that to be as broad as possible. And then a serious or complex medical condition, again, undefined. And we're hoping the state will say, well, we're going to define it as such until the federal government says, no, that's too broad. So really we're pushing California, and I think California has this view as well, to broaden it and to keep it as broad as possible. And then finally, a physical, intellectual, or developmental disability that significantly impairs the activities, one's activities of daily living, obviously bathing, clothing, things like that. So right now what we know is that California is proposing to exclude certain populations, certain waiver, home and community-based service waiver populations. Also, they are planning to exclude the CCS eligible kids, California Children's Services population, if they're over 19. And then also those who get enhanced community support, which is sort of another subject. It's a managed care benefit to do for certain target populations to be able to expand and be able to get a higher end of community support, case management, and then community support services, which is managed care benefits that are available. Again, more specifics later. I think lastly that the department is also looking at claims data that they have, managed care plans have, to say, oh, what diagnoses can we include in this list? What claims, what services or procedures that they're currently getting can we include to automatically exclude people? The goal is to keep you out without having to raise your hand, so that the state actually says you will be exempt because we have data that shows us that you're exempt. That's the goal, and I think that's important. So one of the next things I just want to quickly jump into that's related to this work requirements criteria is the 6-month redeterminations. As you know today, in order to be on Medicaid, you have a 12-month, an annual redetermination requirement. That is important because the longer you go without being redetermined, the better chance you're going to stay enrolled. We know that that's true from all the data, and that when you have to do paperwork to keep on the program, you're going to fall off. So this now new requirement means that you have to get renewed every 6 months instead of every 12 months. That's the same population as is subject to the work requirements, community engagement. So that means every 6 months they have to show that they're still meeting the work requirements, community engagement requirements. So that's a look back onto what's happened to them in the period between their redeterminations. It also means that we know people are going to fall off because of this paperwork requirement. More frequent redeterminations, more high risk of being terminated. The state estimates about 300,000 people will lose their coverage just from this alone by June 2027, and that will go up to about 400,000 by 2930. That's in addition to the about 1.4 million they think are going to lose coverage from work requirements by itself. So this is a significant and meaningfully terrible burden on people. So we know that's going to also drive up the insurance rate, uninsured rate. There are not a lot of good options for people who are uninsured. We know that we've had these old county indigent programs that basically have gone away because we've almost had full insurance for people when we either state-only funded or Medicaid for those who are low income. So that's been such a critical sort of success of California's history, and now we're really sort of peeling away at that. So shortened retroactive coverage for Medi-Cal services. Again, currently today, everyone who gets on the program, who applies, they can look back 3 months before their application month and say, hey, I have medical bills that are unpaid, so maybe I had a catastrophic event or I was in the hospital and I hadn't applied. Now they can look back, and if they had bills and, hospital bills of hundreds of thousands of dollars, they can get those covered. And that's a retroactive period that's available to them. They're now shortening that to 1 month for people who are subject to work requirements, those expansion adults, and 2 months for everyone else. So again, shorter time means more medical debt, more uninsured, more people who can't get that coverage. There is some legislation on this slide that I'll talk briefly about at the end, but that is essentially our bill package that we have that is with other organizations to help mitigate against some of the harm of this bill. Cost sharing quickly is another part of this legislation. So it requires individuals who are over 100% of the federal poverty and in this, quote, MAGI population to have to pay cost sharing on their services. There are exceptions to this: behavioral health services, primary care services, FQHC, which is federally qualified health center clinic services, rural health clinic services, and others. So there are some exceptions, but that cost-sharing requirement, as we know, causes people to avoid care because they can't afford it. It does allow states to also, it can be up to $35, but we're hoping that California makes it a penny, which is what we have proposed because it can't be zero under this law. So we have proposed in our legislation that's referenced here that it be a cent, 1 cent, and that also what states can do is providers can refuse care if you don't pay it. We're also trying to make that not available in California, so that won't be an option. So that's important for this. There's just quickly a new waiver opportunity, which is home and community-based waiver, available under this legislation that allows them, people who don't meet the institutional level of care, to be able to get services. It's really, it's also a new waiver that you can't increase wait times for existing waivers that we have in California for those who are required to meet the institutional level of care. It has some other restrictions. It also provides some funding to states, $50 million the first year, $100 million in 2027. But I want you to understand that this really isn't as big an impact in California because we have the regional center services that already do not require someone to meet the institutional level of care. So some of the sort of motivation for this part of this piece that got put into the law was really those states where maybe autism-related services aren't available to be covered outside of an institutional level of care. And so this waiver was kind of put in place for that. Then I think I just want to quickly talk about immigrants because this is such a huge area of concern in California. So first of all, just as part of H.R. 1, there's a restriction on who can get federally funded Medicaid services as immigrants. This changes the landscape of what has been in place for a long, long time. So it narrows who is qualified to get Medicaid funded services. They're still qualified immigrants, so they're here legally, but they're still not going to be eligible for federal Medicaid. And that includes these three groups are the ones that will remain eligible, those who are what we call lawfully permanent residents who meet the 5-year bar, Cuban Haitian entrants, and then migrants who came in under the Compact of Free Association or COFA and from certain individual places, and they're again on the slide. H.R. 1, the problem with this reduction is that we have a whole lot of groups, refugees, asylees, VAWA, victims of violent crime, who may be losing their federal funded Medicaid in October of this year. So this is this year, this is very soon. The problem is that the governor has proposed in his budget to about 200,000 of those individuals to lose their coverage of state-only funded Medicaid and be put in only restricted Medi-Cal, which is emergency only or pregnancy related, very limited services. So that's the current proposal. It's not law. It's a proposal the governor has in the budget. Finally, there's a couple of things that already happened and also are about to happen in the governor's budget. So this is California specific, which is the freeze on state-only funded immigrants being able to get enrolled as of January 1. That's in place now. So those who are undocumented, who can't otherwise meet these criteria, can't just get on the program today. There's a freeze on the program. And those who are on the program are going to have to start, they're going to lose dental benefits next year, and then they will also be subject to premiums at some point in the future in in 2027, July 27. So again, there's some exceptions, which I don't want to go into specifically now, but that's an important thing to understand, that immigrants, even in the state-only funded programs, are being sort of impacted as they're also losing coverage under H.R. 1. And then finally, just exceptions, so you should also know, children under age 19, those in foster care, those under 26 who are former foster youth, they're not subject to these cuts, so they should be able to keep their full scope Medicaid, Medi-Cal, whether they're state-only funded or federally funded. So there's a definition of them on this slide. And then sort of legislation I said I would talk about. We have a package of bills that Western Center, our office, Justice and Aging, and Health Access California are sponsoring, and AB 2161 by Bunta, who will be here later, talks about protecting Medi-Cal under H.R. 1. So one of the things that does is it stops work requirements from being imposed on state-only funded immigrants. That is part of the governor's plan, to force state-only funded immigrants to work and be in compliance with the work requirements. We do not agree with that, and we don't think that should be so. So we have a legislative bill to try to say that should not happen. Also some other protections there as well. And then limited cost sharing, which I mentioned earlier, is in our AB 2208. So 1 cent, you can't refuse care even if you don't pay the 1 cent. So really it'll be a cut to providers. And then some also restoring retroactive coverage to 3 months, even if the state has to pay for it out of state-only funds. So we're trying to roll back some of those HR1 harms that are happening in the state. And then 2201, which is, it says reducing administrative burden on Medi-Cal. That is really to try to make sure that we can get people on and stay on as quickly as possible with its least amount of paperwork as necessary. So there are some flexibilities the state has to, like, say, we can see your income hasn't changed, or we can see your income's under 100%. You don't need to do anything to keep on that program. We're trying to make it easy for you. We don't want you to have to keep giving us the same information over and over again. So those simplifications are in that legislation. And then finally, the 1202, which is Weber-Pearson bill, and that's to require a data dashboard, like we had it with unwinding, to be able to see what's happening with the program, who are getting cut off, why are they being terminated. We need all of this information to help us know what's happening in California. And there's also more outreach in that bill as well, and to require for the counties and the plans to do more outreach to help people know what's coming. Okay. Lastly, I think there's also an IHSS budget proposal you should be aware of. If you're going to visit your representatives, let them know that you are not in favor of the budget proposal, which is to shift costs to the counties from the state for IHSS services when they meet a certain threshold of hours per month that the person is utilizing. We think this, the counties are obviously extremely opposed to this. Advocates are also opposed to this as a way to shift costs and ultimately think that the counties will then reduce the number of hours people are eligible. This impacts kids, it impacts adults. We're trying to keep those services in place with the cost sharing as it exists today. The last two are really more specific items as well, related to like a backup system that IHSS currently has that they're talking about getting rid of, where you need you need to get a provider quickly because you don't have a provider in place, or the provider you have for personal care services is limited in what they can do, additional hours. And then finally, on the last point, there's a proposal it's strange that you have to put this into law, but that for-profit organizations can't charge you a certain amount for IHSS fair hearing representation. We don't really understand why people are being gouged for helping people keep on the program, but this apparently is something that needs to happen, is to limit for-profit organizations from charging people excessive amounts. All right. Thank you very much. I'm happy to answer questions later. There's some resources, and I'm going to kick it to Nancy to help be more positive.
Thank you, Kim. I want to apologize for the banging. We're working on it. We know it's distracting, and we apologize. I think a lot of times we have to work with noise and distraction, and this is just another opportunity to do that. I also want to take a moment, you guys, did you know that today is the Affordable Care Act's birthday? 16 years, a lot of you made it possible, and I want to start with saying that we can do the impossible. I remember when the Affordable Care Act wasn't here, and I remember bringing home my daughter, Amelia, from the NICU and thinking, we've already used her lifetime cap, and she was born with pre-existing conditions. So I know it's hard right now, but I also know that together, when we work with people like NHELP and we work with people like you in the rooms, that we can do anything. So I'm going to start with that. I want to say where I come from, which is before I was a caregiver, I worked in community health centers and behavioral health. I interned at UCSF, and I thought I knew Medicaid. But that understanding was incomplete. And it was only after I became a foster parent and then a foster-to-adopt parent of children with medical complexities and special health needs that I understood what the Medicaid service delivery system actually looked like, or at least part of it, and what it looks like when you're the one responsible to navigate it. And what I experienced was not a coordinated system. It was fragmented, siloed, and at times extremely difficult to navigate. For our families, Medicaid is not simply a safety net. It's the system that sustains daily life and medical stability. It's an infrastructure that lets my children live at home. It's also what, they live at home, I don't sleep, so I often think, thank you. It supports specialty care across multiple providers, physical, occupational, and speech therapy, behavioral health services, durable medical equipment, costly prescriptions, home nursing and in-home supports, school-based services, and in theory, care coordination across multiple systems. These are not optional services, they're survival. They are what makes it possible for children with complex medical needs to live at home and stay in their communities. This is Lala, and I just want to make a nod to Packard for the work done on care mapping. It has been life-changing for me. And this is Lala's care map. Lala is identified by the system as an African-American former foster youth born prematurely to a mother who did not receive prenatal care. She lives with medical complexities, rare diseases, learning disabilities, an intellectual disability, ADHD, and fetal alcohol neurodevelopmental spectrum disorder. And those are just a few of the labels that she's been given by the systems that care for her. But that's not how she identifies herself. She identifies as a Black teen, a lover of dogs, anime, and ramen, not necessarily in that order, and after her recent 18th birthday, as a grown-ass woman. It's a lot, you all. Over the past year, through the Department of Rehabilitation program, she identifies her occupation, and I quote, "a goat milker and nurse to premature baby goats." So there's a gap between how systems define her and how she experiences her life. And that gap is not unique to her. It reflects a broader pattern in Medicaid, where there's often a disconnect between how systems are designed to work and how families actually experience accessing care. With federal and state policies shifting under H.R. 1 and related to implementation changes, that gap could widen. These are the exemptions, and Kim already did this, so I'm going to go briefly, from the mandatory work requirements for H.R. 1. I see this as an opportunity for us all to ensure that promising policies don't become increasingly problematic practices. Families are asking for implementation that protects access rather than creating new administrative barriers. Even with my background working in healthcare, understanding systems, knowing how to advocate, I have often struggled to get my children the care and the benefits they need. And on more than one occasion, I have completely failed so many times. I can't even imagine facing new and additional barriers. And if that's difficult for someone with my level of access, my level of privilege, it becomes much harder and sometimes functionally impossible for families without those advantages. This is not about individual effort. Systems determine what's possible at the bedside. Those closest to the problems are closest to the solutions. But in Medicaid, policy and implementation and those perspectives are not consistently centered. Okay, I have a little speaker note issue. Sorry, you guys. I accidentally printed my child's 90-page prescription list instead of all my speaker notes. But what I want to say is that we're not arguing as families, we're not arguing against accountability for public programs. We're asking that implementation reduces barriers and burdens by using existing Medicaid data and clinical records, so families are not asked to recreate information the system already has. So the bills Kim referenced are going to be critical for our families. We're asking that families not be required to repeatedly prove information that's already known across eligibility systems, providers, and plans. We're asking that coverage loss from administrative processes be prevented whenever possible, especially when families remain eligible. So we don't want to lose families to kind of administrative churn. And we're asking to inform the development, implementation, and oversight of the policies that save our children's lives. Because from a family perspective, how these policies are implemented determines whether coverage is maintained, lost, or accessed. Medical crises, and this is just a little bit of we've got some recommendations that Kim referenced. One of the things that we want to make sure is that when families experience medical crises, that families don't lose coverage because of administrative timelines. So we all know that medical crises don't follow administrative timelines. Families are managing ICU stays, travel for specialty care, and complex treatment schedules. And at the same time, they're expected to meet renewal requirements and documentation deadlines. When those systems are not aligned, families can lose coverage even when they remain eligible. So we want to look at protections for that. And sorry about that, you guys. I'm having a little slide issue. The other thing that is an issue for us too is that when we have coverage interruptions, we have clinical consequences. So for our families, canceled surgeries, that results, an administrative interruption can result in canceled surgeries, loss of therapy placements with long wait lists, interruption with medication, and regression for developmental progress with our kids. And I think some of us were talking last night about just even with the shift to Medi-Cal RX from CCS, how some of our kids have had interruption in their medication schedules, and it's really impacted, I'm not picking on CCS, but it's interrupted how our kids access clinical care, which impacts, can they go to school, and are they able to do other activities? So this is of particular concern as we look at other policy shifts. The future of Medicaid must include families, and I want to take this back to lived experience. After we lost my husband, Medicaid became a lifeline for our family. In California, about 43% of children with special health needs rely on Medicaid or CHIP. So these policies affect a large portion of families like mine who are managing complex care. Medicaid policy and implementation must reflect the realities of complex care from the family perspective. Policy solutions should be informed by those navigating the system every day. Medicaid also makes it possible for me to say yes. I was able to bring home an infant from the NICU with a prognosis of blindness and severe intellectual disability. They weren't sure my daughter would ever walk or speak. That decision, she does now, let me tell you, both. That decision depended on access to specialty medical care, regional center services, and in-home and community-based supports. Without those systems in place, that kind of decision would not have been possible, as this predated the ACA, as I mentioned. My daughter, again, had met her lifetime insurance cap in the first year of life, and she was born with a number of pre-existing conditions. And that is what this conversation is really about, making it possible for families who have children and youth with special health care needs, letting them love, live, and thrive in their homes and communities. And that looks like protection in the continuity of Medi-Cal coverage for children, more accessible programs and services, culturally concordant workforces, improved care coordination across specialist services and programs, expanded access to home and community-based care, and support for innovations driven by family and youth priorities. Because these are not abstract policy choices. They determine what's possible for families and what's not. And I want to end with this. Those closest to the challenges of care often see solutions first. We have a ringside seat. And the question is whether or not we can structure systems to recognize, utilize, and build upon that knowledge. Thank you.
I was thinking, first go Lala, but also this is what the resistance looks like. Thoughtful, attention to detail, and minimizing the harms. But we're also, don't forget, if you're looking for a silver lining of HR 1, we didn't get block granted. The EPSDT entitlement still exists. We will lose coverage for children, but it will be significantly less than for adults. And if we fight really hard and I have really sharp pencils, we will be able to protect the vast majority of children's status in Medicaid. I know some folks are projecting a 20% loss in children coverage, Kim, at Georgetown. I don't believe it's going to be that high. I think we can do better. Right now, between 92 and 94% of all children in California are covered by a health insurance benefit. And I'd like to think that together we can keep that number over 90% if we hustle. But it's going to take a lot of work like what you just heard about to get there. And this is where I'm going to ask you to retain that sense of two things being true at once, that there is resistance to be had at every opportunity. But there's also something that's been going on, which is a few years ago we decided that, and I'm going to use clinical language, our mental health system sucks. And we had an extraordinary leader, Secretary Margali, at a time of an extraordinary budget surplus, And you saw some things happen in California that I want to hold because they still exist. They're still really important. And this transformation of our children's mental health system is happening right now. And you need to know about it. Because children with special health care needs have disproportionately high challenges with behavioral health. And not because they're pathological, but because it's hard being sick. And this opportunity that I'm going to take you through quickly in 7 minutes or so is about how mental health is changing. And if you remember nothing else about what I'm about to say in my very quick slides, help me reimagine mental health as a support for healthy development, not a response to pathology. Something that almost all children get, because we have built a toxic culture for our children, and we now must teach them how to survive in it. And I'll just start with this data point, and I'm going to go flip through the slide quickly after I do this data point. But just so we can all be real, suicide surpassed cancer as a cause of death this year for children. All the rest of this data you've probably seen before. It's a uniquely difficult time to be young, and we've landed in this extraordinary moment where literally 1 in 4 of our young adults has seriously considered committing suicide. That means had a plan, had a method, had a time frame. So making healing-centered systems mean we have to actually incorporate these things that are driving the challenges young people feel, which is adversity, racism. I know we're not supposed to use this language anymore, but I spent my entire career working around young people, and I would say 15 to 20% of the young people I ever billed Medicaid for were actually mentally ill. The other 80%, really bad stuff was going down in their lives. But I had to bill adjustment disorder not otherwise specified, right? Does anybody else know that one? Yeah, to get young people the support they needed. And we are now learning that there's a new approach. And finally, our reimbursement policy and practice has changed. And what it's changing from is we have to reimagine how we pay for and deliver. And I'm going to give you some very specific examples of what those things are. Just because in the interest of time, I want to go right to them. This is the Medicaid is sexy slide, you guys, but the point of this one is Medicaid is a part of every system that you work in, okay? And I know it's a hard thing to hear, but as Nancy said, it can be this transformative action for social justice, for healing, if we get it right, but we have to steal it from the medical model. We got to pull it back and make it more joyous and connected. And it has to be more relevant to young people who got the most toxic messages of our culture in 2009. We put the internet on mobile platforms in 2009, and we removed the filter. Those messages that our children saw weren't new. They were the messages of this culture that says women can't be president, that fame is merit, that wealth is value. Those are not real, those are not true, but that's what we told our children, and they saw that and they despaired, okay? So we now must teach them how to survive and thrive. And Medicaid has made some fundamental challenges. So this is where, again, I'm going to ask you to hold the duality. As we fight, as we sharpen our pencils and put our hands up and do all the stuff that you just heard, know that some really big things just happened. And they are, first, we remove diagnosis as a prerequisite for care. You no longer have to meet DSM-5 criteria to get a mental health service in California. Yeah. You qualify based on an experience of discrimination, housing instability, food insecurity, or adverse child experience. This is so important, y'all. When we were working on this with Nancy, we thought this was a little bit of a tokenistic thing. It turns out to be a fundamental thing. So it's changing the way we think about mental health. It's super important. We must reimagine the workforce, meaning there'll never be enough of us therapists. Thank God. Okay? And we have to accept the reality that between 70 and 80% of therapists are white. And I like white people, we're cool, we got a role to play. But we know that when your treating professional shares your lived experience, the outcomes are always better. So we have created 4 new provider classes in Medicaid: wellness coaches, community health workers, certified peer counselors, and doulas. If we get it right, we could legitimately bring 20 to 30,000 new providers who look like the young people we serve, because remember, 80% of Medicaid are kids of color. Now, it's not going well, y'all, okay? That's what I'm going to say. We've had a real struggle. We created these workforce classifications. We thought they would come in, and they haven't come in at the rate we wanted. But remember, enhanced care management and community supports also do not require a licensure to provide. So you with me? This workforce isn't just about the new providers. It's also about the case management and care coordination benefits. Geez, I can't read that. Can anybody tell me what my third one is? Oh, yeah, sorry. We created a new benefit in Medicaid. Remember, low-income folks, thank you, low-income folks interact with the healthcare system the most frequently taking their babies to the doctor. But babies don't go to the doctors by themselves. And caregivers were invisible to the Medicaid system until we created a new dyadic benefit that allows us to provide caregiver mental health in pediatric primary care. This is called the dyadic benefit. It's transformative. It's also not going well, but it's happening. This one is really important for everyone here to hold. We passed a groundbreaking legislation in California that made schools automatically in-network for all managed care plans. This is called the multi-payer fee schedule. And it's really important to hold that, like it or not, Lori, we have made managed care the new center of the universe, okay? And we could literally spend the next, decade talking about the merits of whether we should have done what we did. But at the heart of this transformed landscape is the ascendance of the managed care plan as the center of the Medicaid universe and the narrowing of the role of the carve-out programs. And again, we could debate good or bad, but it is how it is. And one thing we've done is we said schools are now automatically in network, meaning for 53 services, 53 codes, if it's provided in a school-based setting or school-linked setting, health plans, commercial and Medicaid, must pay for them. This is called the multi-payer fee schedule, and it's really important. And it reimburses community health workers and wellness coaches and case management and screening and assessment. It's a super big opportunity. And finally, we changed the financing. In particular, coming up is something called high fidelity wraparound. This is a really important new benefit. It's a set of bundled payments that specialty mental health, and I'll maybe just close with this slide and not do the rest, but just to be really clear, we have a bifurcated public mental health system. We have county mental health, called the specialty mental health system, and we have non-specialty, which is the managed care plan. And don't believe the hype, y'all. The right system is the one that cuts you a check, okay? Like, it's not the way it's marketed it to be. But this year, we'll probably have as many kids get a service through the non-specialty system as the specialty system for the first time in history. So you want to be able to navigate both. And if you're a provider, you need to navigate both. The county mental health system provides the best rates in the nation, 3 times Medicare. The non-specialty mental health services just got a bump to 87% of Medicare, so more reasonable than they've ever been. Essential for providers or advocates is the ability to manage both sides of that coin. You want to understand how to access the county mental health system as well as how to navigate the non-specialty mental health system. Because we're up against time, I'm going to call it there. 2 minutes. We have 2 minutes.
2 minutes.
Do you want to do questions or any comments? Did I say anything that pissed you off, Kim? No? Okay, good. All right. Yeah, Ben, go ahead, and then I see you over there, too.
So
Yeah.
Quick question for Kim, actually. You said that exempt CCS people over 19 are exempt from the work requirement. And my question is that only until their CCS ends at 21, or is that up until they're 26 years of age?
I'm going to repeat the question. So Ben is asking whether or not CCS benefits extend past 19 to 21 or beyond in terms of the exemptions that Kim talked about for HR1.
Well, that's the current thinking at DHCS is to exempt all CCS eligible children who are covered by the work requirements if they're in an expansion group, right? So it's important first to know that a lot of people who have disabilities are not going to be in the expansion population. So if they happen to be, then they will be exempt if they're getting CCS services. If they age out, there will have to be another basis for them to get that. And if they have a disability, there's a lot of those medically frail categories and others that they might qualify for.
Yeah, people with SSI are not part of the expansion population. Critical. Yes?
My question was, as a parent, are there any keywords that you would provide or any phrases that you think that would be helpful when talking to providers about behavioral health requesting? Because I found a lot of times providers say, I need ABA therapy. Then it's sort of like, you have a kid with autism. So do you have anything, especially with your
Yeah.
For the Zoom world, it was a question as a parent about language around behavioral health, and I'll let Alex take it from
Yeah.
there.
So what I would recommend here is understanding that two-sided coin I said. And remember, they're not mutually exclusive. I still get this all the time. Like, my kid is getting a service from the county mental health plan. Their managed care benefit doesn't apply. That's not true. So if your child is enrolled, I'll just do LA for example. If you're in LA Care, and you're also getting a service from LADMH, you should be able to get a wide variety of services. And if you can't, call Kim, because she'll sue him. But what I mean by that is, it's not just therapy, it's not just meds, it's not just beds. The behavioral health benefit array in California includes case management, care coordination, psychoeducation, therapy, and various forms of intensive care coordination, ABA, ICC. So my recommendation is, unfortunately, knock on both doors hard. So if you know your managed care plan beneficiary number, it's on the back of your card, call it and say, my kid needs more, they're not getting it, and then do the same with the county. Maybe we'll just take this last question, go ahead. Yeah.
To follow up on the answer that you just gave, so what you're saying is like you put all the burden on the families, and like how do you navigate? Because like Nancy was saying, like with the privilege that we have, and
Yes.
even the knowledge, we're already like having to knock on so many doors, and it's so difficult. So this is like an equity issue almost.
Yeah, man, it was beautifully framed. You're putting, the answer I just gave tells the hard reality that the burden is on you as families to navigate this broken system. And go ahead.
It's not so much like burden. I mean, yeah, the burden of families, but what happens to the individuals who actually need this care? And like, we're just saying like, well, too bad, you don't have anyone that can advocate for you.
Well, I want to be clear, I'm not saying that you don't have anyone to kind of, yeah,
I'm saying that.
yeah,
I'm saying like the system is built for this. Yeah, I'm sorry.
yeah.
I didn't make that.
No.
Will you repeat that just for the Zoom audience, please?
Well, I'm not sure I'm going to do, I don't want to paraphrase it and do it injustice. Yeah, maybe we could give her a mic so she could, thanks, yeah.
Okay, I am going to repeat it. Please, I'm not attacking you. I'm
Bring it.
sorry. I just want to say, like, the system has been built in a way to put, like, it's not, yeah, put the burden on the families. However, we are forgetting about the people who need it the most. So we should find a way to just sort of like make it in a way that is actually accessible, because this is an equity issue. It's not like, yeah, we have like the county mental health is extremely difficult to navigate to begin with, and it's because it's divided by counties. It depends on the resources and whatever the county has. So, and then you combine it with the other system. It's just like a lot for families.
Yes.
So,
Yeah. So I think the point I was trying to make there is that young people who are enrolled in a managed care plan, which is now 90% of all children, like when I worked in an emergency department at Children's Oakland in the early 2000s, 90% of kids were on fee-for-service Medi-Cal. Today, 90% of kids are enrolled in a managed care plan. And enrollment includes benefits that you can access, that you couldn't access before. And every young person who meets criteria for county mental health also meets criteria for enhanced care management. So to the mama who asked me that question before, your child qualifies for enhanced care management. If you're anybody in this room, your kid should be getting ECM. So that's one very specific piece of language you should be asking for. And I think that learning how to navigate your benefits as a managed care plan beneficiary is about the only counsel I can offer you.
Can I just add one thing, which is we are trying to really ensure that there is no wrong door in the system, right? And that there's a closed loop referral obligation on managed care plans to get you into specialty mental health if you need it, to make sure they follow you around the system. That is the managed care plan's responsibility. So we need to hold them accountable for that. We have consumer assistance across the state. I can happily give you somebody that will help you navigate those doors if there is a need. But it's true, they all like to say no and go over there. That's not right. That's not the right answer.
Yeah. I think we have time for one more question. Yeah.
All right, so I got one question from Zoom here from Lisa, which is, are the 5 booms, are they related to Cal-AIM?
Great question. Thank you, Lisa, for that question. I wish we could remove all of the branding of reform. Because whether it was CYBHI or Cal-AIM, the answer is yes. It was both. Okay? So the CYBHI was the $4.4 billion investment that the state made to transform its youth mental health system. But it was inexorably intertwined with Cal-AIM. And trying to unpack which one gets credit, So the answer to that very good question is it was both. And ESSER and ARPA. And we had this moment of time where there was enough money to reimagine the system. And we had some courageous leadership that took advantage of it. But all it did was set a future state. And changing practice is going to take us decades. So, and I'll close with this thought. In the 1980s, we decided everyone needed a primary care physician. And there was never going to be enough PCPs. So under the leadership of extraordinary physicians like Dr. Thomas Bodenheimer at UCSF, we envisioned this theme called team-based primary care. And what that meant was we expanded scope. We added LVNs and MAs and NPs and PAs. So we added new people to primary care. But we also shifted who did what, when, and where. So when you came in, the doctor didn't weigh you. The doctor didn't see if you had a podiatry visit. That was done by somebody else. That is coming to behavioral health. That same delivery system reform. Like, why should we be sending young people to a 50-minute psychotherapy session when that's not what they want? That's not what they're asking for. The future of mental health is a clinician working with 10 community health workers, managing a panel of 400 kids. And more likely than not, you're going to get it at your school. So these changes that were made through a combination of the CYBHI and Cal-AIM and some one-time investments that came during the pandemic and the telehealth exemptions that were codified, there's probably more, Kim. This package of changes, don't worry about assigning it to a specific initiative. It was a bunch of stuff that happened. But those 5 essential things that changed is what I would tell you is the opportunity landscape. And I hope you can join me in trying to take advantage of it. Thanks.